Olá e sejam bem-vindos ao LungTalks, um podcast da Sociedade Portuguesa de Pneumologia. Aqui vamos conversar com especialistas internacionais para explorar os mais recentes avanços, as inovações tecnológicas e os desafios da medicina respiratória, uma área em constante evolução. É com grande entusiasmo que iniciamos esta nova jornada com uma série de episódios dedicados à pneumologia de intervenção, onde abordaremos de forma descontraída e informal os temas que estão na linha da frente do desenvolvimento científico e tecnológico. O meu nome é Helder Novaes e Bastos, sou pneumologista no Hospital São João, no Porto, e serei o vosso anfitrião nesta série. E fica connosco para uma conversa informal, mas inspiradora. No episódio de hoje temos a honra de receber o professor Eric van der Eyden, que é professor de pneumologia de intervenção na Roundbound University Medical Center e é o presidente eleito da European Association of Oncology and Interventional Pulmonology. Vamos, neste episódio, conversar sobre o seu trabalho em broncoscopia assistida por navegação e, em particular, versando sobre o Cone Beam CT. Eric, thank you so much for joining us for this brand new podcast for Sociedade Portuguesa de Pneumologia. I'm very happy to have you to meet you again. I was very impressed with your work when I visited you in Nijmegen, and so when I thought about this podcast, I knew you had to be the first one to join us as the president-elect of AIBIP, and yeah, so I think we have. Me personally, I have a lot to learn from you guys in Nijmegen. Not just the way you approach the peripheral lung nodules, but all the all infrastructure and all the all the progress or working process, in fact, that you have. So, very happy to have you here with us.
Well, thank you, Elder. It's an honor to be on your podcast, and I hope that we can have a nice conversation that will be of interest to your audience. Welcome, everyone, whatever you are doing at this moment. It's nice to at least be in touch with you.
Yeah, so the hot topic for pulmonologists right now, I think this will be the big challenge and also the big opportunity for pulmonologists will be lung cancer screening. So lung cancer screening has already proved to decrease the mortality of lung cancer. We have several trials that with positive results. One of the most important trials were based in the Netherlands and also Belgium, the Nelson trial. So far as I'm aware, there are already 7 countries in the world with national programs. The USA, they have the oldest one, then China, and also joining China, Taiwan, South Korea. These Asian countries also include patients with familial lung cancer, but not in non-smokers. So they have broadened the inclusion criteria for non-smokers, but with a few features of risk. And so far, as I'm aware, 3 in Europe, in Czech Republic, Poland, and in Croatia. So, as my first question, so what do you think what is missing for the lung cancer screening being more widespread in Europe? So only 3 countries, even yours. So in the Netherlands, you are involved in your own hospital at supplying data for the Nelson trial. So why isn't Netherlands or other countries in Europe already undergoing lung cancer screening at a large scale?
Yeah, so I fully agree that it is very important that we should support all our governments to start with screening. Europe is still a bit lagging behind. We've shown the evidence indeed that screening will reduce cancer mortality, and the big issues in our country is the selection of patients. So for now, the proof has been gathered in patients who are smokers or former smokers, but in the general the data that is available from the population, it is not possible for our government to invite people for a screening program as they do for colon cancer screening or breast cancer screening, and then it's known, well, from this age, and you need to have this, you need to be female or not, or male, and then you can enter into a program. That is difficult for lung cancer because there's no registration on the smoking behavior. And that is why what is keeping our government from starting. We're still discussing it, and we're trying to overcome that issue. But that's what brings us slows us down at this moment. And the other issue, of course, is the concern that many other abnormalities will be detected when you do a low dose CT screening. So it will it will generate more, lots of more work than just the cancer screening that is of
The
concern.
thyroid and the heart disease and so on.
Yeah, and interstitial disease. So there's a nice paper out that has been published by the ERS on the secondary findings in the screening program, and how we can address it. And so that it is more difficult to start lung cancer screening than it is for breast screening. So it's more challenging, but I think we all should move forward and start working at it, and then discuss afterwards on how to tweak which patients or which part of the population we should include, and which part we can stop screening. But it's more politics than it is medical. So our medical point of view is start and better screen one patient too many than miss lung cancer, because, well, we show that if we start screening, you'll find early stage lung cancer, and then you have a opportunity for curing and keeping these patients active in the community, so they can still contribute to the society, be at work, and live longer, instead of having a stage 4 disease where they have palliative treatment and very costly immunotherapy and so on.
Yeah, it will. I'm also a believer, so I think lung cancer screening will completely change the landscape of. So we have, you might have 75-80% of advanced stage, and we'll have 75-80% of early stage lung cancer.
Exactly. Yeah.
So you were comparing, and that's curious, comparing with breast cancer. So performing biopsy in for breast cancer is,
Easy.
it's easy. Yeah. So you have ultrasound and you have a needle and just take it. It takes just a few minutes.
Yeah.
So there are a few estimations that say so there will be an additional workload of 2.6% of bronchoscopies, more or less 3%. So more or less for each 1,000 CT scans, so 30 bronchoscopies will need to be made. So we know how lung cancer will find small nodules, usually less than 2 centimeters, usually at the upper lobes and peripheral ones. And so far, we have been, asking the radiologists to do take these biopsies. And fortunately, interventional pulmonology has come from a long way of new technological development that helped us to start getting good diagnostic yields in such nodules. But still, it's more expensive, and for each case, we still take longer than just taking a percutaneous biopsy. So, how do you feel about this? So, you have been involved in many developments at different stages of, from conventional to more advanced bronchoscopy for these peripheral nodules. So I remember starting with the, fluoroscopy guidance, then the emergence of radial buzz, which is cornerstone in our approach. Virtual bronchoscopy, I'm not sure if you had virtual bronchoscopy at your department. I've seen it before in Leuven, but now we have in Porto electromagnetic navigation. I know you also have that experience. And then how this has led to cone beam CT navigation bronchoscopy. Can you tell us more about your story of, so how have you been involved in these developments?
Yeah, so there's lots of technology that has developed and that has opened up the possibility to target smaller lesions and more in the periphery of the lung. And of course, well, if you have a lesion that is really easily accessible with transthoracic needle, then or ultrasound transthoracic or central in the airways, that you can practically see it, or just use the radial EBIS probe to guide your TBNA or biopsy, then please do that and take the easy route or the easiest route for that patient, so you have the quickest and most convenient way of taking a biopsy. But indeed, the when you have these small peripheral located lesions, often the radiologists are reluctant to, or it's not possible to get a needle in without increased risk because of COPD or emphysema, bullae, vasculature that is in between. And also, we know there's been a small abstract, but it has not been published in full. There's the Veritas trial. So that was really the first study to randomize transthoracic needle aspiration compared to navigation techniques with the modern technology. So I think it's also included robotics. And they showed that the diagnostic yield is equal, but the complication rate is much lower. So and especially for pneumothorax, the patients that require a chest tube after a diagnostic procedure with the transthoracic is somewhere about 9%, 9 to 10%, compared to 1% pneumothorax that requires a chest tube in the navigation group. And so that is a big advantage. So it's equal diagnostic yield. It is safer.
The bleeding. I want to, also the bleeding. We
Yeah.
can often see bleeding in endoscopy, but so we have a zoom in in our screen, so usually it's not troubling us. The
No.
bleeding,
The
even with
overall
trial
bleeding is also
biopsies.
much greater. Yeah,
Yeah.
indeed. Yeah. So hemorrhage is much lower, and overall complication rate for the is 31% in CT guided biopsy compared to overall 6%, so including small bleeds and stuff for the transthoracic. And the other issue is that when you have well, with the modern CTs, you see many more nodules. So often it's not just one single nodule, but multiple. And with the transbronchial approach, you can do them all in one session and be sure that you correctly stage. And we often now diagnose 2 or more cancers in the same patient at the same time with different molecular profiles. Yeah.
So let's think. So in Portugal, we have a few centers. So far as I know, we have 3 public hospitals with navigation bronchoscopy and electromagnetic bronchoscopy. And we have 1 private that has both navigation, electromagnetic navigation, and also has cone beam CT.
Yeah.
So for the others, they are just starting and want to go deep into this field, because we don't have comparative analysis of electromagnetic navigation and robotic and cone beam. We have, and usually the data, either single or multi-center data. I think there's almost always, at least, a bias of selection. So if I'm doing such a trial, I would enroll patients that I believe I can do that biopsy.
Correct. Yep.
It will go, the diagnostic yield will go up, because for such nodules, I think, wow, this is so subpleural, it's so difficult to go there. I'd rather go to CT guided biopsy. And do you feel like this? So the question would be, since we don't have comparable trials, what would you recommend people to acquire? Should they well, I believe that everyone should have radial bus. Everyone wants to do this. This is the so buying number one, in my opinion. I
I
don't
agree.
you
Yeah, radial
agree?
EVIS is very nice to have for every endoscopy suite. Even if you do not want to go for the very small ones, it will still help you if you want to target the more central ones. And yeah, if you're just beyond the vision of the lesion itself, and then there's three subsegments, then you can choose the correct one to get a good diagnosis, and that quickens your procedure. But yeah, if you need to choose, well, if well, obviously it also involves a lot of money because these systems do not come cheap. Um, and but every technology also has its limits. So the electromagnetic navigation system, it functions very nicely, but it is better in the upper lobes because there's less movement. And if you are going to the lower lobes, then you have breathing. There are different bronchi that run more or less in parallel, and then this you can the EM signal cannot really discriminate if you're actually in the correct sub segment bronchus if they're running in parallel, and then you run the risk of not ending into the lesion that you want to end up in. Uh, and and to be sure that you're in a lesion, you'll need to have 3D imaging, and you can have that with cone beam CTs or with modern tomography systems like body vision. And also the new EMN system comes with the integration with the C-arm that will give you a sort of a 3D confirmation of your position, but yeah, you still have the limitations of the EM and the electromagnetic navigation resolution in space, because there will be
Yeah.
a error margin of a couple of
CT to
millimeters.
body divergence. Yeah. So
CT to body divergence, but also the measuring of the positioning will have an error margin. So yeah, so combination with some navigation supports and 3D imaging is the best combination, and you can also see that in the robotic system. So when they were first launched, people tried them without any 3D imaging confirmation, but now everyone is stepping up to integrating a mobile cone beam CT into a robotic system. So that will add another 300,000-400,000 euros for a mobile CT on top
yeah.
of your on top of the robotic system.
Yeah, because the robots they didn't so correct for the CT to body divergence, so that was something new with the Illumi site, and now yeah, so that's why you use cone beam. So
Yeah,
let's take just a brief description or a brief um, explanation about your history behind cone beam CT. Uh, so why did you go to cone beam? Because I understand that you believe that's the best way to define tooling lesions. So to be sure
yeah,
we are there, and so because we sometimes I discuss with my colleagues. So we have, the EBOS, radial EBOS yield of around um, with mental GPS or using navigation, you usually find the radial EBOS sign in about 85-90% of the cases. But even so, the diagnosis it's around 15% lower,
yeah, yeah.
around 70%, more or less.
Mhm.
So the thing is, how can I increase this 15%? So if I know I'm there, or at least I believe I'm there, how can I increase this diagnostic yield? So you think one of the tips will be Conbeam? Yeah. So and the others, what do you think about cryo? So can you just discuss this two things with me, please?
Yeah, actually there are two questions. So how did we end up with cone beam? Well, as Dutch, we do not like to spend a lots of money. So we always want to get a free ticket. And our hospital bought a cone beam CT, so in a hybrid OR. And that opened, well, we saw the potential of that system, because a fixed cone beam CT does not only make 3D images, but that you can also segment the lesion and superimpose that lesion on the fluoro images, but that is called augmented fluoroscopy. And then you can, by using different rotations or angulations for the fluoroscopy, it will still it will move with that different positioning. So you can show that you can get in and or that you are above or below a lesion, and you can also indicate the route or the bronchus that leads close to the lesion and that you need to follow. So that's what we have developed in using. And the first thing we had the EMN system, so the Super Dimension, the version 7. And the first study that we did was comparing, use the Super D as a navigation tool or use only cone beam as a navigation tool. So to get to the small lesions, so the sub 3 centimeter lesions. And just like in your park, you have reached your destination, and then do a CT and check if you are correct. And if you use for the small ones, use the Super D system, the electromagnetic, then it was correct in 50%. And when I tried it with the cone beam CT only, so with the augmented fluoroscopy, we were correct in 75%.
Increase 25 around.
Yeah.
Around 25 with your diagnostic yield. Yeah.
We further worked with the cone beam CT to work to increase that opportunity. And to fine tune the technology, but also with cone beam, and there's a difference between the biopsies that you refer to. So when you show that you are there, and then start taking biopsies, then there's a gap in a drop between the diagnostic yield there. So coming back to the difference between the navigation success and diagnostic yield, so the 10-15%. Also with cone beam, this is still the case, and this is where there's a couple of things. So what we use now is a catheter which is not that we cannot actively steer. So it's just an extended working channel with a pre-curve and we use the catheters that come with the Super D system still. So they have a pre-curve and you want to rotate it but you cannot angulate it. So when you're in front of the lesion and you put in a needle, it will stretch out because the needle is stiffer than the catheter without a needle in. And every biopsy tool that you use has different stiffnesses, and that will stretch out the catheter, and then you're just grabbing just next to the lesion instead of into the lesion. So active steering is an important issue to overcome this, and well, that is also what the robotic systems will then show you. So we did a study. We recently you were present with one of the last patients that we did in that study, where we are comparing the use of the robotic plus cone beam CT. So also looking at, well, if the robotic navigation part will tell you that you get there, are you actually in the correct position? So to overcome CT to body diversion. But also with robotic, you see that you then need to most of the time adjust just a bit. So to tweak the tip, to bend it just a bit more, and to actually get a center hit with your needle. And that is what the robotic system will then allow you to do. But yeah, that could also be overcome with the development of steerable non-robotic catheters that can be a competition for the robotic system then. And the other issue with the robotic is that it will maintain that curve. So with the catheter, the extended working channels that we use, it will stretch out, whereas the robotic it will remain the
Remain the
position.
same position.
Yeah, so that is an important advantage there.
I was very impressed how fast it was to find the lesion with the robot. So you were using the ion.
Yeah,
So I really thought it was even easier than doing manual bronchoscopy. So human bronchoscopy, it was so fast and you and so with vision towards the hand. So
perfect.
so
Yeah,
can you explain a little bit? So there's a like iriscope through the extended working channel that you remove and then you place the tool,
yeah,
the biopsy tool. So it's steerable to the end and you still get the vision till the end.
yeah.
Then if you combine this with CT with the cone beam CT, well, this was fast. And can you share with us what is the diagnostic yield of of that? You have um, a round number to tell us about this combination, how far it can go?
Yeah, we are aiming to it is submitted for the ERS, the first analysis that is. I'll need to look it up so I will not make mistakes. Just a sec, I need to check it. And because the study that we actually are doing is that we want to compare the yields with propensity score matched non-robotic cone beam CT
Yeah.
patients. So gonna match size, location, the density of the lesion, all of that, and we'll find for if every robotic nodule, we'll find one or two non-robotic nodules that we have done with cone beam CT only. And I am looking for the latest data, but that we can share is that well, last year we did an interim analysis, and now we have done 181 nodules in 131 patients, and the nodules had an average size of approximately 12 millimeters and diagnostic yields with a strict definition. So at the end of the procedure, what the biopsy tells you it is benign or it is malignant is 82%.
Wow. So that's and for that size, it's really robust data. So we'll come to approximately the what is described for CT will be, I think, 85. So it's really quite similar for that size. So
Yeah, for the Veritas trial where they did randomize the nodule CT compared to a navigation, that was where is that? That was 76 somewhere in that range. 76% in both arms, and the nodule size was 15 millimeters in both
okay,
arms.
yeah.
Yeah.
So one last question. So with those data, do you still need rows, rapid on-site examination? So, you confirm several times you are in lesion. So you might have a robot or not,
Yeah.
but yeah, then you have cone beam, you have radially buzz. Do you still need rows?
Yeah, I think so that it will still be of additional value because even with all this high tech and you really think you're in there, then still um, if the on-site evaluation will tell you, I'm just seeing blood, normal tissue, don't see anything cancerous, then you are still able to adjust just a bit to sample a other part of the tumor or the lesion and still get a diagnosis and because you've already invested a lot of time and money in getting there and at this nodule, and yeah, it it is just the last extra bit to be sure that you have sampled enough and sampled in the correct position, and that it is also enough for the molecular analysis that you'll need. So I still like to use rows and have the on-site discussion with the
Yeah.
pathology team. So it's also fun to get your immediate feedback that you've hit it, and yeah. But it can also be very frustrating. So you're working there, sweating, and they're just telling, nothing, nothing. So that's the backside. But
Yeah.
yeah,
And
then
sometimes there's nothing there, but still you get diagnosis. That's
yeah,
well, it's not. But well, cytologists are not just around the corner, so I think many of us will have trouble to get
yeah.
such a good support as you have.
Yeah,
Fortunately,
no, agreed.
I
So
can.
that will be also become more difficult for us, and so that's also another field that we need to look into, so that we
The
can
pulmonologists, yeah,
or
I know there are
pulmonologists in
pulmonologists.
UK, or that we have distant with
Oh
the
yeah,
internet have distant help from pathology or cytopathologists, so that could be overcome. So if you have one good cytopathologist, he can handle online 20 bronchoscopies at one time. So but you need to find solutions to get good quality of slides and good quality of digital images. So because scanning of cytology is still difficult, it can be very thick, and then you can't really see it in just one digitized slide. Yeah,
yeah. Thank
but
you. I will
working
just
on
say,
that.
yeah, I was just and now to the question just to end is because it's been very fruitful talk with you, but I think we have to one last question. So because
Mhm.
radiologists still argue they have a cheapest and fastest um, procedure to offer. We already have discussed the pneumothorax and the bleeding, so the side effects of the percutaneous approach. In your opinion, as an expert in the field with lots of experience in doing bronchoscopy, advanced bronchoscopy for peripheral lung nodules, which cases do you still ask the radiologists?
So when the radiologist can do a safe aspiration, we'll still ask them. So if it's a single one, and they usually in the report already they write down in our hospital, we can access this, and then we'll send them to them, because then it's the quickest and the fastest route. But we've been working with our navigation system for many years now. So now at this point, our radiologist also will write if the cardiologist or whoever has seen this patient for a CT, advised to refer for navigation bronchoscopy. So also our radiologists are now already trying to help and select patients that they can do, and that are better off with navigation bronchoscopy. But it's a team effort, and it really depends on how good your own radiologist is. So if you want to start a navigation program, it's also wise to involve them and to pre-select the ones that they can easily access and the ones that are more difficult. And if there's more than one nodule, then it's not better to do a navigation procedure. And if there's any doubt of the involvement of a nodal metastasis, the hilar lymph nodes or whatever, and then you still need to do an EBUS, then you can combine navigation bronchoscopy with an EBUS in a single procedure, and then you have a diagnosis and a staging done immediately. So that's also an important selection.
Yeah. Thank you, Eric, for these very insightful thoughts and for taking your time with us. I'm looking forward to meet you again in Lisboa with ACP. So
Yeah,
we
looking
will be
forward. It'll be a
sharing.
great event. Yeah,
Yeah,
everyone
great
should
event.
come.
We are very happy about it. So looking forward to see you and your team, and really happy to show you around. So thank you
Thank you.
very much for this time. And as a closing remark, I just will now change for Portuguese. So para agradecer a todos que estão aqui a ouvir e para, por favor, coloquem o vosso feedback para nós sabermos de que forma é que nós podemos ainda melhorar este podcast, que convidados e que temas nós podemos abordar e vemo-nos no próximo episódio. Thank you, Eric, once again.